tutorial is about history and physical examination. As you know, it is the most important part of your journey as a medical doctor, which is to get to know your patients. You want to know what is it that they are going through. So during history taking as well, it is the time that you develop your soft skills with your patients, how you want to speak to your patient, how do you gain trust from the patient, okay? So I will guide you through and how you can do this during your ophthalmology posting, because a good history taking can lead you to the right diagnosis, and also it determines, it helps you to focus on your examination so that you are, during your examination, you know what to focus on, and also it also helps you to choose the type of investigations that is needed. And also, it can also determine the functional impact of the condition of your patient. And additionally, like I said, it's also for you to build trust with your patients as well. Okay, so let's look into the symptoms that is related to the eye. Okay, so we can give the symptoms into two. Okay, we can divide it into two, whether the patients have a visual complaint or non-visual complaint. All right, so the visual complaints, we will go into depth what they are. But then these ones, the subsequent ones, they are the non-visual complaints. So I just want to see where the laser point. Okay, all right. So the non-visual complaints are these, are the pain, photophobia, discharge, eyewitness, and so on. Okay, so let's go into each one of them. And always remember that for each symptom, you have to dig deeper. You have to question further what is the onset, whether it is acute, whether it's subacute or chronic. Okay, usually acute it is within days, 1 to 2 days, and chronic is within weeks to months, and subacute is in between, because this determines whether you are thinking of which disease. All right, and then for the course, whether it is stationary, progressive, or it's getting better. This is also important. You want to know how the severity of the disease is, whether it's self-limiting or it is something that you need to go in depth with, okay? All right. And of course, the duration, whether it is recent, it's long-standing, and also sometimes another thing is that whether it's an insidious finding, which means that the patients actually which means that the patient just realize it by chance. Okay, sometimes you get patients who actually do not have any symptoms, but they go to you because of a certain event. For example, the common ones are the diabetics. They have, when we ask them, how do you know that you are diabetic? What were the symptoms? And then they will say that, oh, it's just that a family member of mine has a glucometer. Then she tested my blood and shows that the sugar is 20. That's when I knew that I have diabetes. But otherwise, they have no other symptoms. So those are what we call insidious findings. Or for example, something that is relating to the eye. Some patients actually have been having blurring of vision due to cataract. And then it's in one eye. But then the patient does not realize it until he or she covers one of the eyes. Maybe she was like one of the hair terjatuh ke apa, dia terjatuh kat situ cover, then it was there. Oh, this eye actually I cannot see when it's covered. So those are, sometimes we get patients like that as well. Again, it's important to include that in your history. Okay, so we know that the symptom has not been bothering them until recently when an incident happened that they realized about it. Okay, so for the visual complaints, we have diminution of vision, which means that the patient has reduced vision. The vision suddenly becomes not sharp. When they try to read something, then it becomes very blurry. So patients can actually say that they have reduced vision. Or maybe there is visual field defect. Maybe they can specifically say that there is something blocking. I can see where it is. I can see an image, but I do not see certain parts of it. So those are what we call visual field defects. And then we have the optias, which I'll go in depth into that. And then we have diplopia, which means there is double vision. And then there are also floaters. This is a very common symptom in which the patient feels that there is something inside the eye, and also visual hallucination. Okay, but the patient will not tell you that they have visual hallucination, but they will just say that they see something, and maybe the family members tell you that actually I don't see that thing, you know. Okay, so for the diminution of vision, this is a very important symptom in ophthalmology. Okay, so you must remember, out of all the symptoms that I have mentioned, there are three symptoms that is very alarming, which means if you are working as a doctor one day and then you call me up, you want to refer a case to me, and then you tell me about these three symptoms, it will alert me. It will say, I will say like, oh, I will want to see the patient within the next few hours or few days. Okay, so what they are reduced vision, acute onset of reduced vision, eye pain, and also eye redness. So remember these three symptoms. I will remind you again and again throughout this tutorial. Okay. So with this diminution of vision, it accounts for most of our visual acuity, and also it's a common thing that the patients come to us is because of their reduced visual acuity or diminution of vision. So it's important for you to describe the laterality. Which side is it? You must remember we have two eyes. Okay, so you have to ask the patient which side that you don't see, left side, right side, or even if it's bilateral, okay? And then you ask them, what is the onset like? Is it sudden or gradual, or it happened within a few days? You want to know when it actually happened, and also the course, whether it's stationary or it's progressive, it's getting worse, or it's on and off, it fluctuates. Sometimes it's clear, sometimes it's not clear. And then you want to ask the duration, like I said just now, and then whether it's recent or it's long-standing. All of this are useful information because each of the eye disease will present differently for the types of diminution of vision. And also, I will really, really appreciate it if my students ask a little bit extra by asking the patient, what is it that you mean by diminution of vision? You'll be surprised with the answers that the patients will tell you. Some will say blurry, some will say it is patches, sometimes they will say, because all of this is very important, because sometimes patients, they do not know how to describe what they see. So when you probe further, it's important. For example, like cataract, the patients will usually complain of generalized blurring of vision. And then it depends on the types of cataract as well, because there is a type of cataract which this one is more of an introductory. For each one of them, you will learn this, in your future lectures on what are the exact description for each of the eye disease. Okay, some of them might have a decreased vision only at night for a condition like retinitis pigmentosa. Or Malays, we call it rabun ayam, which is at night, they will not be able to see. Okay? And then we also have to ask about the associated symptoms, which are pain and also redness. So remember, I said that three symptoms that is alarming to us, which is reduced vision, pain, and also redness. Okay? Now, for patients who actually complain of visual field defects, the patient will say that there are certain areas that they cannot see. So it's important that you ask the patient which side that they do not see, whether it is on both the both eyes, which is binocular visual field defect, or uniocular visual field defect. That means it's just one side. Okay. So you must remember, you just had your anatomy class just now, right? So you know that if it is binocular involving, that means the visual field defect involves both eyes. It is usually the lesion that is above the optic chiasma, while the ones that involves only one eye, it's usually earlier than the optic chiasma. Unless, of course, they can actually have, but it's not absolute. Okay, for example, like retinal detachment, if they happen to have in both eyes, of course, they will compare both eyes. But this is kind of like a rough guidance for you to lead where the lesion is. Okay. So now I know that you all listen really well for your anatomy lecture, but I just thought that I just put this up to remind all of you what I meant by the optic chiasma. Okay, so we know that this is the visual pathway. This is the left eye, and then all the nerve fibers make up the optic nerve. Okay, and then the temporal fibers will go uncrossed while the nasal fibers will cross. So at the place where they cross is called the optic chiasma, And then subsequently, they form the optic tract until they synapse at the lateral geniculate body. And then the fibers that leave the lateral geniculate body are called the optic radiation, and they will run to the visual cortex, which is the occipital lobe. Okay, so if the complaint of the visual field defect is in one eye, then most likely the lesion is on here onwards. Okay, it can be the optic nerve, it can be the retina itself, it can be just the macula and so on. But if there is involvement of two eyes, usually it is beyond. Okay, optic chiasma and beyond. Okay, like we have the common one, the very favorite one, like the bitemporal hemianopia. You know that the lesion is at the optic chiasma. Okay. So one of the other symptoms, like I said just now, the opsias, all right? So we have what we call the metamorphopsia, which means that the image they see is distorted. Okay, we have nowadays like a lot of applications, even on the MacBook, the photo booth, you can make the effects of fish eye, frog and everything. So those, they distort your images. So we have actually patients who actually complain of the distortion. Okay, for example, if you see in this tree, this forest, okay, a normal person will see it straight, like there's nothing wrong here, but a person who complains of metamorphopsia complains is like wavy. They will say like, doktor, saya nampak tiang lampu tu straight, tapi ada tempat tu dia macam bengkok-bengkok sikit. Ataupun they will say, bila saya baca, nampak shape A tu macam pendek sikit, macam bengkak-bengkok. Okay, so usually patients who complain of all these opsias, the lesion is at the macula. Okay, so you see how important it is when you plug the history properly by probing further, getting the patient to actually explain to you what is it that they mean by there is a visual symptom. So you know that when patients complain like this, then it can guide you. Oh, I think the lesion is in the macula. All right. So the other type, besides the metamorphopsia, is the micropsia, which means the objects appear smaller, and macropsia, the objects appear bigger. Okay. All right. The other type is the chromatopsia. This one, the objects, the color objects appear differently. Like for example, in this room, this is the normal one, but this one there's like a hue of yellow. And these ones are usually lesions that is involved with the optic nerve, or in general, like the color blindness, that is congenital color blindness. Okay. So this is another important symptom that is also alarming, which is floaters. Okay. So if you look carefully at this picture, you can see that they have like strands of hair. Sometimes the patches can be bigger. Okay. So if patients complain of floaters, or even if you have family members who call you, I mean, I'm sure you now that your family knows that you are a medical student, you'll be getting calls and, like, oh, you have to help me. I started to have this symptom, and you want to help them. So if anybody complains of floaters, especially a recent onset, within days, please tell them to go and see an eye doctor, okay? Because this is another alarming sign, alarming symptom for patients, okay? Because we fear that it could be retinal detachment or retinal tear, that has a retinal tear or can lead to retinal detachment, or even they might be having uveitis or vitreous hemorrhage from bleeding inside the eye. All of these things, don't worry if you don't know it. Once you go along through the lectures, we have been introduced to the other diseases. Please revisit this lecture again. That's why I intended to record this so that you all can view again. Then when you watch it again, once you have learned about the disease, it makes sense to you. Okay, now if it doesn't make sense to you, great. The more confusing it is, the better, because your mind will find ways on how to seek for the answer. So again, after you have learned all the other diseases, please revisit this lecture again, which I will put up on my YouTube channel. Okay, so if for floaters, it's important, especially if it's an acute onset. But it's for some patients, there is a condition which we call posterior vitreous detachment. It is an aging change. Usually, we see that in patients who are high myope. High myopes are those patients who have rabun jauh or short-sighted. They can have the symptom of floaters, but if it's been there for years, it's not something to worry, because that results from contraction of the gel that becomes opaque. That one is not really alarming. But if it's an acute onset, then we must get the patient to come to the eye clinic faster. Okay. All right. So the other one is diplopia. Okay. I'm very sure you all remember that three symptoms of raised ICC, right? A very common one. I still remember that from my medical student. Of all the things, we always remember these things, right? Diplopia, projectile, vomiting, and also headache. So diplopia is something that you have to ask in depth as well. Okay, there are two types of diplopia. All right. So again, it's uniocular or binocular. All right. So binocular diplopia, it is usually something that involves the alignment. Okay. But if it's uniocular, that means the patient close one eye, he only sees that the diplopia is only in one eye. Then usually it is something that is related only to the eye. Okay, for example, for the uniocular diplopia, for example, the lens. You know how patients have cataract surgeries and then we implant a synthetic lens. Sometimes that lens becomes dislocated. So when it is dislocated, what happens is that the patients will see it as a double vision, but it's only in one eye. Okay. However, in binocular diplopia, it happens in both eyes, and usually we see this in patients with palsy, nerve palsy. You know, it happens because by right, our eye is supposed to move together. They are supposed to work together between the left eye and the right eye. But in nerve palsy, that involves the 3, 4, 6. I'm sure you remember from your anatomy lesson of the EOM. We have all extraocular muscles are supplied by the third nerve or the oculomotor nerve, except for two. LR6, which is supplied by the sixth nerve, and then the SO4, superior oblique, is supplied by the fourth nerve. Okay. So when which there is nerve palsy in either 3, 4, or 6, the eye becomes misaligned. And when they become misaligned, that's when the patient complain of binocular diplopia. So you will see these patients in my clinic when patients actually complain of binocular diplopia. The true binocular diplopia, they walk into the clinic like this. Okay, they're not flirting with you. It's just that when they do that, they see things better because the eye. There is no formation of double image in the brain. Okay, so always remember that. And for your nerve palsy, let's say, I just want to say this. Let's say if you're working in the in the general clinic, like the primary healthcare, and your patients have nerve palsy, what you can do to help the patient to feel a bit better until they come and see the eye doctor is just to put an eye patch, so at least they be comfortable, because sometimes they can get headache from the diplopia. Okay, all right. Any questions? If you have any questions, you just interrupt me. Okay, I like interruptions during the lecture. Okay, no one is interrupting me. That's good. Okay, so we also have the non-visual symptoms. That is important. One of it is pain, and then eye redness, and also eye discharge. Okay, so usually if it is pain, it is something alarming. Anyone should be free of pain. Okay, so when a patient complains of pain, especially eye pain, they need to be seen directly. It's an emergency because we want to see what is it. Most probably it is wrist intraocular pressure, or we call it IOP. Okay, if I say IOP, you know it's an intraocular pressure. Or it could be an inflammation that's going on. It could be an infection that is going on. So that is an alarming symptom. Okay, eye redness as well. As we know that the patient has conjunctivitis or pink eye or red eye, that one is alarming because it's an infection. Discharges are usually because of eye infection as well. Okay, and the other ones is include headache. Okay, sometimes patients complain of headache, but it's actually an eye disease. Okay, I actually had one patient that I encountered this year. No, this is last year. Okay. So this lady, she's 6-year-old. She was admitted to the medical ward because she complained of headache. So they investigated her, and she said she's really having a headache. Then they investigated her, and then somehow, incidentally, they found that the patient has hyponatremia. So the patient was admitted into the medical ward to correct the hyponatremia. Was corrected, but she still complains of this headache. So somehow along the way, one of the smart doctors, one of the smart housemates, I believe, asked her, what is it that the headache that you feel? Then she said, no, actually I feel headache here, and sometimes my eyes actually I cannot see very well. So then when she started to mention that she couldn't see very well, then someone clicked. Someone thought, oh, okay, maybe she's having an eye condition. So they referred to us, and indeed what she had was an acute angle closure glaucoma. Her eye pressure was very high, and the eye findings was actually quite subtle. I mean, for a general physician, may not even notice that the cornea was a bit hazy, but the cause of her headache was actually because of the raised intraocular pressure. Okay, so just bear in mind that when a patient complains of headache, dig further. If you cannot find something that makes sense why the patient is having a headache, just be sure. Sometimes it could be an eye disease. Okay, all right. So the other symptom that the patients might complain is a foreign body sensation. Okay, foreign body sensation is usually related to foreign body entering the eye. Okay, as we know, one of the common ones is something that goes inside the eye. Okay, I had a girl who was a student of UPM. She came to the eye clinic saying that she cannot see. Her eyes are very painful because when she was sitting at the cafe, there was a birthday party of someone, so they threw the confetti. So one of the confetti went inside her eye. So then she started rubbing her eye, and then she came to the eye clinic very panicking, thought she's going to lose her sight. So I inverted her eyelid, and then I saw that confetti, a pink color, a small piece of paper. Then I removed it, and she was like, oh my God, she felt so relieved. And she had some corneal abrasion, like a very superficial abrasion of the cornea, but it was subsequently okay. So foreign body sensation is also something that is important in ophthalmology as well. Okay. The common ones, another one is the welders. Those people who work in the welding factory, when they weld and they don't put on their goggles. Sometimes they put on their goggles. They have this shield in front of their eyes. It's just that the metal pieces or the percikan goes inside the eye, and it becomes embedded onto the cornea. So we remove it at the slit lamp, and then they feel better. Okay. The other common one is itching. As we know that anything that involves itching and gatal-gatal is usually allergic. Okay. So it could be that. And the other one, just I forgot to mention, the foreign body sensation, it could be because of dry eyes as well. Okay, dry eyes can present with that. The cornea, the latticine cornea becomes very rough, that the patients complain of foreign body sensation. Okay, and the other one is, of course, like I mentioned just now, the red eye and also eye discharge. Okay, this eye discharge, sometimes it's not discharge. Patients actually have watery eye or epiphora. That one is also can be caused by dry eyes, okay, watery eye discharge, or also sometimes there is a problem or an abnormality in the drainage system of the eye tears. Okay, so it's important to differentiate that as well, whether the patient has watery eyes or epiphora. If it's epiphora, it's because of the drainage system. Okay. All right. So if it's the red eye, we have to ask, is there any eye discharge, or it's just the red eye only, or is there any pain, any drop in visual acuity? So you see, all these three symptoms are the common ones. I said that three alarming ones. Okay. Let's look at this picture. Okay, so this patient has a red eye, okay, and then there is a corneal opacity. So patients like this, usually what he or she will complain of is the eye pain, and then there is reducing visual acuity, and also most of there is an eye discharge, because this looks like a corneal ulcer that is healing towards healing, okay. But in this kind, it's a different kind, right? You see the cornea is clear, but the conjunctiva is injected. So usually these ones, they have conjunctivitis or allergic conjunctivitis, okay? And then the third picture, you see that the patient has conjunctival injection. There is a red eye, but if you also look at the eyelid, it's different than this image above. This eyelid is swollen. Okay, so that leads you to a different diagnosis of why the patient actually complains of a red eye. Okay, the other one is eyelid swelling. Like in this picture, you can see that this boy has an eyelid swelling, and this condition is what we call orbital cellulitis, or sometimes the less severe one is called the preceptor cellulitis. Okay, this one is also very important because patients like this, they will not complain only of eye swelling, but they will complain of pain. So is it alarming? Yes, they will also complain of visual symptoms. Okay, so it's alarming. So this kind of patients, you have to refer to an eye doctor immediately. Okay, the other one is proptosis. Proptosis means there is protrusion of the eye. Okay, I have a question. If anybody can answer, I want a voice answer. What is the difference between proptosis and exophthalmos? Can anybody answer me? Anyone? Okay, so since anyone is not answering, let's put that. Yes,
I'll
I
try
heard
to
it.
answer.
Yeah.
I think proptosis is like a abnormal protrusion of the eyeball, so it can be
Okay.
protruted outwards. But exophthalmos will be more towards a grave disease symptom, where it is associated more to the thyrotoxicosis.
Yeah, absolutely. But you are right. Okay. Proptosis in general is an abnormal protrusion of the eye. Okay. But when we say exophthalmos, exophthalmos is proptosis. But like Jihan cakap tadi, Jihan kan, was it you who answered? So I saw that your microphone was on. Okay.
Yeah.
So if it is exophthalmos, it is proptosis that is specifically to the thyroid eye condition. Okay, very good, very good. Thank you for answering. Okay, and we move on. The next one can be sometimes patients may complain of discoloration of the sclera. Okay, it can be jaundice or blue discoloration like in this condition. Okay, some of these things are just something that's nice to know, but just remember that the important ones are the eye pain, uh, eye drop in vision, and then eye discharge and also eye redness. So, and also floaters. Different. You really, really have to be alert when patients actually complain of these symptoms. Okay. So when we ask about the history, not only we ask about the symptoms, but there is a component of other things. Okay. So I always tekankan benda ni, which is the name. You have to know the name of the patient, the age, the ethnicity, the gender. Okay. So in my clinic, um, when the students want to present, I always want them to present with the patient's name, okay? Because usually when you present, the patient is there, and it's not nice, when you are like this patient, this patient. Okay, if I was that patient, I'll be wondering like, okay, are they talking about me or they're talking? It's a sign that you want to show respect as well. Not only that, it's also for identification, all right? Because then I know, oh, this patient Madina ke or Fatimah ke, so I know who we are talking about. Okay, and then of course the age, because with age it leads to the which type of disease, ethnicity, the same thing, and also gender. So these some diseases are um, affected by the, or one of the risk factors is affected by the age, ethnicity, and also the gender. Okay, name tak ada, it doesn't matter what name it is. Okay. All right, and we also focus on what is the chief complaint. Um, can anyone tell me what time is it now? 12:30. Okay. All right. So, what is the chief complaint? And then we also have to ask about what is the history of the presenting complaint, the past ophthalmic history, the past medical history, the medication, the family history, the allergic history, and also the social history. Okay, so all of this is pretty much the same, like how it has been in your medical posting, in your surgical posting. Okay, but what I want to highlight here is the chief complaint. So you must know what is it that what brings the patient to seek medical attention. There must be a reason why the patient suddenly wants to see a doctor. So that is the chief complaint. All right. You will be surprised that sometimes patients actually do come with, I mean, you see like the eye, like for example, like that patient that I mentioned just now, she complained of headache. So that is the chief complaint. All right, it's not the eye pain, because what brought her to the hospital was the headache. So that is the chief complaint. All right, then we focus more on the history of presenting illness. So what is it that we want to ask it during the history of presenting illness or history of the presenting complaint? Because before you want to get more information about the disease, all right, about the chief complaint, yang headache tadi, onset dia macam mana, whether it's gradual or it's sudden, and then of course the cause, and then the duration, since when, is it constant, is it intermittent, and then especially for visual complaints, I also like to know how severe it is. How severe is it? Does it affect their daily activities? Are the patient still able to read? All of this is very important, okay? In the management of the patient, then we know how aggressive do we want to act. Is it bothering their daily activities? All right, and then it's also important to ask whether has he or she sought any medical attention before they actually presented to you, because we also want to know whether was there any treatment given, especially in the context of corneal ulcer. Okay, we receive a lot of patients who have corneal ulcer, but actually they went to the GP first and they were given eye drops, and it didn't work. Then they come to us after weeks when they know that it didn't work. So all of these are valuable information. Okay, and also if there is any pain, we also want to know what is the precipitating and also the relieving factors. All right. So for the past ophthalmic history, you will need to know about the past clinic visit. Okay, this will guide you on what condition they have. All right, is it like something regularly, usually something like glaucoma or diabetic retinopathy, or it is just a one-off visit, or it's a new patient. All right, and then the past ocular surgeries is very important. We want to know whether the patient has had any cataract surgery before. Any refractive surgery is something that you have to ask, because nowadays a lot of people have had cataract surgery and refractive surgery, so it is important to know that as well. And then, with regards to the past ocular surgery, we also need to ask, okay, all right. And then the past, we move on to the past ocular trauma. Yeah, that's very basic. You need any trauma into the eye. And then we also want to know what is the visual acuity previously in both eyes, all right? And then the refractive error history, the glasses history. So if the patient is wearing glasses, ask them, at what age did you start wearing glasses? Was it clear when you started wearing glasses? Do you wear glasses regularly? And also, you also have to ask whether the patients wear contact lenses or not, okay? Especially in cases of infection, like I said, the corneal ulcer. We want to know whether the patient wears contact lens or not. Now, if the patient has refractive error, I said it's important to know why, at what age do they start wearing the corrective lens. It helps us in determining whether the patient has amblyopia or not. Because some patients, they come to us and they want to go for cataract surgery. So we try to give the best lens as possible, and then we try to estimate how good they can see after the surgery. Okay, and then it turns out like after the surgery they didn't do very well. The eye couldn't see very well, and it's very strange. Okay. But if we had known that the patient has amblyopia, you will learn about amblyopia, then it would have helped. Then, the patients won't feel very frustrated, because we can align with them. Like, after the surgery, there's guarded prognosis, but you will know that you have amblyopia, which means the eye is not seeing very well previously. It's not because of the eye disease. Okay, so patients who have amblyopia, usually they have a very high power, high refractive error, but it hasn't been corrected until that later age. So patients have very high myopia. The glasses are like very tebal. And then when we ask them, at what age do you start wearing? They wear at school age. 13 tahun, 14 tahun. That means it's a bit late, because usually they should be corrected before they are 6 or 7 years old. Okay, so after that, because the patient hasn't been seen very well, so the eye becomes lazy eye. Okay? So this is the telltale of how we know that the patient has amblyopia or not. Okay, so remember the past ophthalmic history, you asked about the clinic visit, the past ocular surgeries, trauma, the vision, and also the glasses history. Okay. Oh yeah, and also the purpose of wearing glasses, whether it's for reading or for far vision. Now again, this one I have to know as well what the patient's medical history is, whether they're diabetic. Diabetic, we work very closely with them. They have to be under follow-up at least once a year. Hypertension, because usually they come together, and also it's a reflection of how well the diabetes can be controlled, which also determines the outcome of the diabetic condition of the eye. So, right, so we'll be having the lectures again with me on Friday on the diabetic retinopathy. Look forward to that. And then if they have thyroid eye disease or rheumatoid arthritis, all these conditions are commonly associated with the eye. Okay. All right. So medications, you have to know what medications are they on right now, and previously what medications were they on. And steroid use is very, very important. We want to know whether the patient is on steroids or not. Two types of steroids: topical and also oral, the systemic steroids. Okay. So if it's systemic steroids, the patients can develop complications from steroids. The patients can develop cataract. And usually with the topical steroids, they can develop secondary glaucoma. So we do want to know. So if patients, maybe you clock at a clinic and then they say that they have an eye drop, we have to know what eye drop that is. If it is a steroid eye drop, you just have to be careful, okay, because you're not supposed to use it without the supervision of an eye doctor. Okay, so for the anticoagulants, it's also important because these are mainly for the surgery, or sometimes they can develop bleeding conditions that we know because of the anticoagulants, and also whether the patients are on any anti-glaucoma medications. Okay, so for you to know whether the patient is on anti-glaucoma medications or not, you can ask them how often do you use it. Usually patients who have glaucoma, they will use the medications lifelong, and it's usually at a specific regime. Okay, twice per day. And where is the medication stored? For example, like Zalatan or Latanoprost, one of the anti-glaucoma medications, we actually store them in the fridge. So these are the telltale signs. So sometimes patients come to you and they do not know anything about their disease, what they are on. So these are one of the tricks of how I actually korek rahsia from the patients of what they are on. All right, allergic history is also very important. We have to know what are their drug and food allergies. It determines whether we want to give which type of antibiotics. Or if they need to go for a scan, they might need to be covered with steroids, high dose of steroids. And also for those patients who have allergy, you have to ask them what allergic reactions do they develop, because it gauges whether how severe is the allergic and whether was there any history of anaphylactic shock. Sometimes they don't know that they have anaphylactic shock, but you ask them, have you had a history of ICU admission because of allergic? I had a patient like that as well. So when I knew that the patient had a history of anaphylaxis, I was very careful, and we tried to avoid giving them things that could cause allergy, like the dye for one of the diagnostic tests in ophthalmology. Okay, so moving on, the family history is something you have to ask as well. Any family history of glaucoma, especially in primary open-angle glaucoma, it is usually a family kind of thing. So you have to know whether the patient has history of glaucoma. And it's twins. Twins is also important. Sometimes it can run in the family. History of malignancy, history of myopia, night blindness, anyone in the family with a poor vision, because sometimes they do not know that the family member actually has glaucoma, but they can tell you like, oh, I had a grandma who was actually blind and she's always on this eye drop. Then you're like, oh, okay, most probably that the patient has a history of glaucoma. Okay, so when tracking your patients, it's important that you ask, of course, sensible questions for you to dig further about what that disease is. Okay, and I do admit that clocking or history taking is a skill that you develop along the way. The more you see patients, the more practice you do, you become better and better, because all of these are stories that will lead you to the diagnosis. Okay, And social history also is very important. Where I was trained in Egypt, um, my professors used to tell me always start with the social history first when you clerk. Okay, you ask their names, what are their ages, where are they staying. Then also you ask the social history. But of course, you don't start right away with the recreational drug use, sexual history. So orang macam terkejut macam, why is this person interrogating me? You don't. Okay, you just ask about their occupation, where they live, because not only you want to build rapport, and also it helps, especially when you know someone's education level. For me, it always helps on how I want to communicate with my patient. You'll be surprised sometimes your patient is actually a doctor. Some doctors they don't actually admit that they are actually a doctor. So we end up like speaking so long trying to explain when it could have been a shortcut of trying to explain about a disease. So always ask about that. And of course, if you know that your patient is from a lower socioeconomic background or lower education background, you just use simple terms so that the patients understand you better. Okay, because your role as a doctor, it is not only to diagnose, but you also want to educate your patients so that your patients know about their disease, they know about themselves. All right, so it's important for you to ask the social history. Okay, with regards to all this high risk behavior, I do not ask everyone. I only ask when the disease that I'm seeing has connection for the high risk behavior. For example, in cases of uveitis, where it can be a symptom or a manifestation of an STD, that is when I ask. Or in uveitis, it can be a manifestation of the drug abuse. They have HIV from the drug use. That one I will also ask. Okay, but in general, you do not have to ask. It can be, but again, the art of asking all this high risk behavior is also very important. You have to call them in a separate room, and if it is involving someone of your opposite gender, I would advise for a chaperone as well, because sometimes it can be you need a saksi lah, a witness, so that it will not go against you, because nowadays we get all kinds of patients. And also always start with a soft front end. Okay, usually I would tell the patients, first of all, I'm very sorry I have to ask this question, but it's a basic question I ask everybody. Okay, because this might be one of the cause of your eye condition. Then I will ask, do you consume alcohol? Do you take drug use? What is your sexual history and so on? Okay, all right, but always start in a way that is polite and gain your trust from the patient. Okay, all right. Okay, so for example, if you have done all this history taking and all, you can start by presenting. You can summarize your history, your classroom history. Okay, like for example, like this one, I give an example. Mrs. B, she is a 60-year-old Indian lady. This is how I expect all of you to present when you present in my clinic, okay? Mrs. B, she's a 60-year-old Indian lady who presented with blurring of vision of the left eye for the past 6 months. Okay, so there we have the chief complaint, and then we have the laterality, and then we have the duration. Now we want to look at other things. The blurring of vision is painless and gradually worsening. Okay, even better if you can ask what the type of blurring of vision. Some patients will say described as generalized blurring of vision. Okay, and then she has no past ocular history of surgery. She has underlying diabetes for the past 10 years, and she is on oral hypoglycemic agents. She has no known food or drug allergies. She has no family history of glaucoma or blindness, and she is a housewife with 3 children. Okay, especially in the Malaysian setting, sometimes I also, but this is some part of the management. I also want to know whether the patient is a government officer or not, or is a pension card holder, because it helps us in our management. All right, especially finance is very important in clerking as well. All right, moving on with 2 parts, we have history and also physical examination. Okay, before I move on, any questions? I'm going to stop sharing my slide for a while because I want to see everybody. Okay, everybody is alert, alert and conscious. GCS is full. Only that I cannot see everybody. I only get to select 1, 2, 3, 4. Only 16 of you. And I know the others macam ramai lagi ni. Okay. So if you want me to move on, do a very cute face. Okay. All right. Very cute. So we move on, okay, which is the physical examination part.
Doktor,
Yes.
I have a question.
Yes,
Kalau
Nadia.
patient datang with the distort images,
Uh-huh.
then how to further elaborate on the distort images?
Okay, very good question. Thank you for the question. So you can ask the patient, first of course, laterality, which eye, or the onset causation, that is basic. Well, you can also ask where is it that they see, okay? Is it in the center or the upper part or the lower part, okay? And then nanti during the lecture of the special test, you will be introduced to this what we call Amsler chart, okay? It is a grid where the patient can specifically draw out the metamorphopsia that they are seeing. If you see just now from the picture that I showed to you, the images of metamorphopsia, the grid, because that one is the Amsler chart. So we give out to the patients on how they do it. But of course, sometimes the elderly, we give them the Amsler chart. Usually, young patients with metamorphopsia, they have macular condition, commonly the age-related macular degeneration or ARMD. We will give them that chart, the Amsler chart. Misalnya pakcik dia bawa balik rumah, seminggu sekali check ni, nampak straight ke tidak. Sometimes they lose it. Of course, I pun tak simpan yang, you know, that kertas nipis macam tu. What I tell them to do is look at their tiles. At home kan kita ada tile kan. So minta pakcik tu, pakcik kalau kertas ni hilang kan, cuba tutup satu mata, cuba tengok tile tu straight ke tidak. So we give them other tools, but that is one of the ways that we gauge them. We ask them what is it that they mean on the distorted vision. Okay? All right. Any questions? Denise, yep. Any questions? No. Tak ada. Okay. Syahira, kalau senyum aja Syahira ni. Tak ada juga. Yang muka-muka yang boleh nampak adalah Tan Jihan, Nurul Nadia, Adam Husaini, Syahira, Hasanah, Jun Dili, Ji Cheng Eng, B Salini, Chong, Denise, Nur Afina, and Kui Hui. The rest I cannot see. I do not know how to get everybody in. Maybe some other time we can have sessions yang guna Zoom pula kan, we'll see what it's like. Oh, okay. Speaking of these sessions, I also want to highlight, we don't have to have like a specific, if you all nak classes yang macam you tak faham ke apa semua tu, just get one of you, or Lihan boleh contact I directly, and then I can allocate time to understand, because this is something yang it's easier to use kan, this kind of platform. So I'd be happy to really guide you because we want to maximize the learning. You don't get to see patients in the clinic yet, but we try to have more learning. Okay? All right. Okay, so let's present again. Wait, just a minute. I nak charge my computer. Okay, I've lost that yang mana nak present tu. Okay, how do I present? I present, I usually dia akan ada that thing of start presentation tu kan. How do I remove this chat? Macam this chat punya ni. The people chat ni apa semua tu.
I think doctor can click on the screen itself. Like,
Oh, okay, betul. Click on
Yeah.
the screen. Okay, your entire screen. Okay, great. All right, so we will move on to the physical examination. Actually, we don't use the stethoscope, yeah? I mean, we use, but we don't examine with the stethoscope. So when you want to examine the tools that you need to go into the eye clinic is the pen torch and also the ophthalmoscope, all right? So we will go in that during other tutorials of how one of the special tests, okay? So when we talk about the physical examination, as you know, in medical or in surgery, we have like the inspection, the palpation, sebagainya. But the in ophthalmology, we have again inspection, we have also palpation ada juga. But we don't have percussion. We do have percussion for certain diseases nak jaga for the catheter semua tu. But we don't have auscultation pun very minimum. But in general, we are mainly we go based on the inspection, okay, in ophthalmology. So the tools that we use, the instrument that we use is called the slit lamp, which we will share about. I mean, you all usually see it. Kalau any eye clinic, we have that machine that we use to check the eyes. So what we look at is the first you can tengok the external eye examination. Okay, so you have to check the eyelid macam mana, the eyelashes. Is it normal or is it swollen like the pictures I have showed you earlier? And then is there any crusted eyelashes? Okay, so you comment on the eyelid and also the eyelashes. You must also remember that the term of the eye sees what the brain knows. So when I have given you this guide, then when you apply it, then you will get to see what is it, the thing that you need to examine. Okay, so moving on, you look at the conjunctiva. This is the conjunctiva, okay, which is the transparent structure that is covering the sclera. I'm sure you remember it from your anatomy just now. So when we look at the conjunctiva, you need to describe whether it is white, like this one is a white conjunctiva. And then whether there is any lesions on the conjunctiva, which I will show in the subsequent pictures. And then to remember the eyelid and the eyelashes, and then you comment on the conjunctiva, and then you look at the cornea. How is the cornea? Is it clear? Like this one is clear. How do you know it's clear? You can see how the iris is. This is the iris, right? And then this is just for the pupil, all right? And then you look at the anterior chamber. Is it deep and quiet? Okay, you will be able to see whether it's deep or shallow based on your experience as well. Of course, it's better when you look at it through the slit lamp. Okay, so you must comment on this on the external eye examination. All right, which also includes your lens status and also the pupil as well. Okay, so for example, like the eyelid, for like this boy, he has a swelling or a lesion at the lower eyelid. So this one we have to describe what is the lesion like. All right. First inspection, what is it? It is like a round lesion. When you palpate, you feel that it is warm and tender and it's erythematous. All right. Then you palpate somebody, you say it's cystic. So all of this you have to describe like how in surgery you need to describe the swelling. It's just the same thing. All right. And then like the eyelash, this one you can see that the eyelash is crusted. It's not the normal kind of eyelash. Most probably the patient has infection, so the discharge becomes stuck. And usually orang kata yang ada conjunctivitis tu bangun banyak tarik mata macam ni lah. Alright. And then this one the eyelid is swollen. You can see it's very inflamed. This is not like a normal eyelid. All right, so please comment on that as well. And then on the conjunctiva, like I said, you have to see whether it is congested or injected. Then you comment whether it's generalized. All right, like this eye, generalized, the whole eye looks injected, the whole conjunctiva. Or if it is ciliary injection, like this one. Okay, ciliary means it is surrounding the cornea. Another name is called circumcorneal injection or ciliary injection. All right, and then if it is sectoral, like this one. Each one of these, by just looking at how the conjunctival injection is, it can negate us to which type of eye disease. For example, when it is sectoral injection, usually it is episcleritis. When it is ciliary injection, usually it is uveitis. When it's generalized injection, it can be an infection or other disease like a very severe inflammation of the eye as well. And then this one is a subconjunctival hemorrhage. Subconjunctival hemorrhage is it is not a dangerous condition unless it is associated with other things like associated with trauma. Then we are worried because it can be one of the signs of a globe rupture. But otherwise, we do get patients yang ada subconjunctival sikit-sikit macam tu. Sometimes it's due to excessive rubbing or the patient is on anticoagulant, so little trauma can lead to bleeding. It is just bruising. But it happens, it is spread because we don't have the skin. But on the skin, if there is bruising, we see it as bluish, but on the eye, we see it as directly as red. It can be scary as well. So just tell your patients that it will resolve within 2 to 3 weeks. All right. Okay. So the next one is the corneal findings. Okay. So if you see, like this one, you can see that the cornea is clear because you see that you can see the details of the iris. It's very different than this one. Yeah, you cannot see how the iris is like, how the pupil is like. So this one is hazy cornea. Okay. And then if there is opacity, and this one is generalized haziness, right? If there is opacity, like a specific lesion like this, you have to locate where is it. Is it in the central part or paracentral, or is it near the limbus? So it's important that any lesion that you find, you must always describe how it is and also locate where it is. Okay, then for the anterior chamber, we have to comment as well on its depth. Okay, just a little bit of pointers. Most of you will encounter deep anterior chambers. Okay, so even in exams, we will give you those ones with the deep anterior chamber, not with the shallow ones, because those usually belong to the emergency ones, and we don't put patients like that for emergencies. For exams. This is what we call hypema, which there is a bleeding inside the anterior chamber, and this is hypopyon, in which there is purulent material inside the anterior chamber. Okay, and then when we talk about the depth, this is how we determine, because some of you, I know you're curious to know what do you mean by depth. So how we look at this is by using a slit lamp. This is how we see it. We can see this is the iris, this is the anterior chamber, this is the cornea. So we gauge the depth of the anterior chamber by looking at the distance between the cornea and the iris. So like this one, there is a pretty good amount of space. So that means the anterior chamber is deep. In contrast to this one, all right, you see that the cornea and the iris and the cornea, the space is very little, which indicates that the anterior chamber is shallow. All right. Okay, so then we also have to comment, you look at the pupil. What is the shape of the pupil, whether it's round or eccentric? Like this one, the pupil is eccentric. And then the size of the pupil, like this one, the pupil is dilated. This one, the pupil is myope. This condition, this patient has a specific eye condition, which you will all learn during your neuro-ophthalmology lecture. So you have to see also whether the pupil is dilated or not. Usually in the clinic, especially the diabetic patients, when you see them, the pupil is already dilated. So again, comment that when you want to present the finding, you can say that the patient's pupil is already dilated. Okay, and then how is the reaction of the pupil? Is it reactive or sluggish? And of course, the RAPD. I won't go into RAPD because there's a special lecture just on RAPD. It's a very, very important component of ophthalmology. All right. Let me look at the lens as well. Okay, like this one, this patient, this one is a normal lens. Okay, we call it phakic. Whereas this one is pseudophakic. You can see that the hue is different. Okay, there is a way for you to check whether the patient is phakic or pseudophakic or aphakic. There's no lens at all by looking at the reflection of the light. Okay, but it's very challenging for me to demonstrate that through this lecture. In the clinic, I will demonstrate to you how you want to check whether the patient is pseudophakic or the patient is phakic or the patient is aphakic. All right, like this one, the patient has cataract, and this one, the patient has a lens. This one is an artificial lens, what we call the anterior chamber lens. And this one is also a type of anterior chamber lens, but specifically we call it iris claw because the lens here, you can see the clip, like claw, macam tu, clip onto the iris. Okay. All right. And also you also have to check for the red reflex. Okay. How many of you kan kalau ambil gambar kan, sometimes you get to see the eye that is red. So that is the red reflex. Okay, like this child. So the red reflex is a reflection of how clear the media is. Okay. So what are the medias of the eye? We have the first, kan the eye for you nak tengok dua kan, the media has to be clear and also the conduction has to be good. So for the media, we can check with the red reflex. If the patient has clear media, that means the red reflex will be seen like this child. Okay, the cornea is clear, the lens is clear, the vitreous is clear, the retina is flat. That's when you get to see a good red reflex. But if the patient has cataract, like this one, the mature cataract, you cannot see the red reflex. All right, so it's important for you to check for the red reflex, to check for the video clarity. So there are different types of red reflex appearance that can tell you which type of condition the patient has, especially in the type of cataract. Like this one, you see the red reflex. By right, the whole eye should be like this. But you can see there are patches, and usually this one is the posterior subcapsular cataract. And this one is like a spoke wheel. Usually it's cortical cataract. This one is a mixture of generalized reduction and also some cortical cataract. All right, so this is one of my favorite questions as well in the clinic because especially when the patient is dilated, it's very fun to see how is the cataract. Okay, all right. And then the next one is the fundus examination of ophthalmoscopy. We will go in depth on how to use the fundus. Actually, we created a video last year on how to do the fundus examination. So please watch the video. I think Dr. Rafida has shared the link on her Google Classroom. So please have a look at that. So when you look at the fundus examination, what you're looking at is the optic disc, looking at the blood vessels, the macula, and also the rest of the retina. All right. So for the optic disc, you need to comment on the color, the margin, and also the cup to disc ratio. The color, like this one, it is pink. Yeah, I know you're thinking that's not pink, that is orange. I think my doctor is here, she'll be arguing with me saying it's not pink. Yes, but it's just a term that like this one is a normal optic disc, so it is pink. But this one, you see the color is a bit pale. All right. And then you see the margin, it has to be well defined. Like this one, you can see the margin very clearly. This one as well. And then this is a large cup to disc ratio. All right. You will learn about this cup to disc ratio more in your glaucoma lecture. Okay. So like this one, you see this is the normal eye, whereas this one is very blurry margin. The patient has papilledema. Okay. Papilledema is a term that you use when the optic disc is swollen in both eyes and it is caused by raised ICP. But if the optic disc swelling is only in one eye and it's not caused by raised ICP, we don't call it papilledema. Okay, we say it's an optic nerve swelling. All right, please differentiate between that two terms. Like just now I said, the exophthalmos and proptosis. It's an optic nerve swelling and also papilledema. Okay. So by the end of these are the components that you are supposed to fill in. You have to take the visual acuity. We'll go into that during the special test. You need to check the RATD. So why I put the right eye and the left eye. So for example, the visual acuity kat sini, you tulis lah 6 RATD, no RATD, normal. Conjunctiva is white. The cornea is clear. AC is deep and quiet. The lens is cataractus. The pupil is round, reactive, optic disc, well-defined, pink, CDR or cup to disc ratio is 0.3. The blood vessels normal, AV ratio is 2 to 3, the macula is flat, the retina is also normal. Okay, so this is what you're supposed to fill in. Do the same also for the left eye. Okay, I know some of you need extra guidance, and also I also created this one. I shared some of you dah tengokkan on the Google Classroom. So this one you can download. You want to write it down again, it's fine. But just use this as a guideline for you to how you want to use it in your clinic sessions when we start the clinic. Okay, so it's a good guide for you to use it. All right, so we have come to the end of this lecture. I will also put up a feedback form onto my Google Classroom page. So I will need you all to give the feedback as well, because it will really benefit me on how I need to change my style of presentation, because my aim is I want you all to really learn really well during this 2 hours of your time. So I will make adjustments based on what you like, and also I will also give you feedback as well. How I will get to know how you are doing or not by certain tests that I will be posting. All right. So the tests or quizzes that I will post on my Google Classroom, it is not relating. It has nothing to do with your exams. It's just something I see it as a feedback mechanism. I want to see how well you understand about ophthalmology, so that before you go to the clinic, memang dah mantap dah all this theory. It's just about applying. Okay. So if you really make use of the quizzes that I post, the MCQ stuff, you will really benefit from that. Okay, but just remember, I said whatever marks you get is just a feedback for you on how you are doing. It will not go into your exam. Okay, just to be clear on that. All right, questions?